Welcome to NeuroNoodle's Neurofeedback and Neuropsychology podcast featuring tech legend Jay Gunkelman. He's the man who has read well over 500,000 brain scans, and Dr. Marie Swingle, author of iMinds. Our goal is to provide information and promote options for better mental health. Hey everyone, if you're enjoying the show and want to help us keep it going, please consider supporting us on Patreon. Your support helps improve the content and brings on great guests and grow the show. Join us on Patreon at patreon.com/NeuroNoodle. But hey, if supporting financially isn't in the cards right now, no worries. You can still help us out for free by liking, subscribing, and sharing this episode. It really makes a difference and helps more people find the show. If we've earned it, hit that subscribe button and turn on notifications so you never miss an episode. The NeuroNoodle podcast is supported by listeners and businesses just like you. Anthony, you only got like 30 minutes because you got a skedaddle. What did you have on your list from your technology group?
One thing that was really interesting is kind of sciencey. They found out that your pupils dilate with your pulse, and meaning they kind of they open and close with your pulse slightly. And I remembered that the alpha, I was reading Yuri Kropotov's book, and I think he said that alpha will go up with visual effort. And so they even found, where were my notes on this? But I'm learning that sort of vision and the EEG are intimately correlated. And somebody posted, I think it was in the Brainmaster group, Santiago, I know, does something called brain spotting. And it fascinated me too, because the paper said that if you have a trauma, that there will be, I think they called it like a resonant part of the visual field. And by focusing there, you might actually address the trauma. So I don't know if Jay or anyone else wants to talk about this connection between kind of vision and the pupils and the EEG and how we might leverage that.
Yeah, there's a new Sebern Fisher who has been talking about this the last year or so. This process called deep brain reorienting. Kind of piloted or shepherded by, or discovered by, I'm not sure how to give him the credit, Dr. Frank Corrigan, who's a psychiatrist in Scotland. And speaking of the visual field, the theory behind this deep brain reorienting, and I'm assuming that it is similar to brain spotting in that regard, in that in early childhood trauma, the visual orientation of the infant to the mom. It's not. I'm not being sexist about this. It is the mother, literally the birthing person who gave birth to that child. And if that orienting of visual systems is inadequately bonded, the child is left with a withdrawal from connection. This is the disrupted attachment theory concept underlying developmental trauma. And they've drilled it down to, Corrigan has drilled it down to a brainstem function of the superior colliculus, which then informs the periaqueductal gray, which then informs the amygdala. So the theory behind this deep brain reorienting and why Sebern is so excited about it is we have no trouble accessing amygdala response, but a little going deeper than that is a little more challenging. How do you get to the brainstem, with a surface electrode? It's a little more challenging, and this deep brain, she feels, is going to be the missing piece for trauma recovery from especially early childhood trauma, based on that attachment theory concept. So I'm assuming it's similar to brain spotting. I've never seen brain spotting done. For that matter, I've never seen the deep brain reorienting done, but it is a somatic, non-language based intervention. This isn't about talking about your trauma. This isn't exposure therapy. This isn't EMDR. It's not a lot of things. But I'm really intrigued by this, and I'm really looking forward to seeing her present at ISNR. And she's got a whole thing going on down in South Africa with Ruth Lanius and Bessel, I think. The three of them are going to be, or Sebern, Ruth, and Corrigan. Sorry, not Bessel.
Wow.
So Corrigan, Lanius, and Fisher are all going to be in South Africa doing a presentation on DBR. I'm very interested in this. So anybody who's a licensed psychologist, go check it out, because I think it's a good add-on for trauma clients. But I think it connects to what you were just talking about, Anthony, in terms of visual orientation for the infant to the bonding parent. Josh is nodding. That makes sense to you?
Yeah. Yeah. I'm a therapist. Trauma therapy is what I do, all day. And the few clients that I do see, because I'm mostly admin these days, are going to be severe trauma cases. And so I do brain spotting, I do EMDR. Neurofeedback is a big part of what we do with complex trauma, because you're good luck trying to do, complex PTSD without it, or dissociative PTSD without it. I mean, my goodness, I don't know what they did with before that, but it is a very, very useful tool for getting people through, acute parts of this story. And yeah, I very much relate to it. And I think there's people probably in the audiences that can relate to it as well.
Yeah. Craig, you got a relative that says hello. He's got a question for you. Craig W. Love to learn more about neuroinflammation. Can you read the rest of the question there?
It says neuroinflammation and its impact on neurofeedback, as well as things that can be done to minimize the intense responses. I have seen earlier podcasts about this. I have noticed, even just with sleep tracking, it feels like friends that go through the process, they even sleep a little worse at night, the night of the treatment, often, not every time. And I'm almost wondering, is some of the irritation that they may get just from lack of sleep that evening? But that's my throw in there.
Inflammation in the brain ends up producing swelling. And if you swell anything inside of a closed container, you're changing the pressure. And things that can collapse, like blood vessels that are filled with fluid, end up having a smaller diameter because of the pressure. And arterial capillary beds can end up having less flow because of the pressure. So inflammation leads to ischemia because of the decreased diameter of the blood vessel. And ischemia is seen really easily in the brain. Migraine ischemia, post-traumatic ischemia, vascular change causing ischemia, vascular anomalies causing ischemia. Ischemia is decreased delivery of oxygen and glucose. So, it's not a healthy circumstance. And if you make the area that has the ischemia work hard, it will actually not work well. If you exceed the impaired supply line's impaired capacity, you actually create hypoxia downstream. Hypoxia creates more edema. It creates a glutamate cascade and cell death. Now, cell death is just as bad as it sounds. You don't want to be doing that. So overworking the area that has the ischemia has to be avoided. Otherwise, you can make big bad problems like cell death in the area, which is why they put people into a coma after a head injury, to not waste the resources on consciousness and actually let the brain heal before they return the person to consciousness. So they're not going to inadvertently overwork an area that's been impaired. Wait for it to recover, the swelling to go down, and then allow them to return to consciousness.
Which is why here in our place where we work with a functional medicine health coach. We look into nutritional platforming. We find out, and as best we can, we're not doctors, but we find out, does somebody have the indications of neuroinflammation? Because we're asking the brain to do an exercise, and we don't want to push people past their tolerance levels. So if somebody walks in and they have disclosed, we have a person with Lyme disease, or they have an absolute diagnosis already of a neuroinflammatory marker, you have to be extremely careful in how you approach doing neurofeedback. Gently, slowly, small sessions, small amounts of time, see their tolerance levels. You can't just charge in there and do a half an hour of whatever. So you have to be very mindful of that. The undisclosed people are the ones I'm most concerned about. People who have no idea that the foods that they're consuming are neuroinflammatory. They're just eating American diet crap, and they're wondering why they don't feel well. It's a combination of, their brain circuits may be dysregulated, but their entire system is inflamed. So whatever limited resources are getting into the brain, it's over. The whole system is overtaxed. So you got to start with make sure that your clients have reasonably healthy bodies, have pretty good diet, are hydrating, kind of the basic stuff. It's not rocket science. And if there is something of note in a nutritional panel, have their doctor address it. Let's really dig down, because it's going to impact how successful we are as clinicians. That's the bottom line.
If I could pipe in here a little bit, we've learned so much from other professions, and even though, the decade of the brain is supposedly well past, we're still a little bit in our infancy in terms of the aggressiveness, and there's no need for that aggressiveness. I mean, something as simple as physiotherapy, you just, after an injury or a weakness in an ankle or a knee, you just don't go in and do 25,000 exercises. You don't go into deep tissue massage before you do surface massage. I mean, many other professionals just walk gently in the water. And then when you know what's below the surface of the water, when you know how many waves in the current, and if there's a riptide, sorry, going with the analogy, then you know how and where to dive in and with what level of caution. And also be prepared to backtrack a little bit when the circumstances change. I think all of us have a little bit of an issue with the aggression, the lack of respect for the sensitivity of the instrument. I mean, the brain is, wow, I mean, it's the master instrument of all of us. But oh my gosh, all those little pieces, we have to make sure that we respect all of them.
You mean we shouldn't be strapping 9-volt batteries to our foreheads?
Maybe tomorrow.
I mean, the biohackers are out there doing all kinds of stuff that you just go.
Anybody else hate that term?
Yes.
You only need 1.5 volts battery. You don't need a 9-volt battery. 1.5 volts through normal skin impedance gives you about the right current for activation or inactivation without blistering. A 9-volt battery, you can blister your skin.
That's very funny. 1.5 volts is plenty. That's going on Reddit. It's going to go on Reddit this afternoon. Jay Gunkelman says 1.5 volts is enough.
Hey, can I throw in, some of this cosmetic stuff that we're doing in terms of like electrical stim on the surface for wrinkles and things? Mm-hmm. I mean, boy, oh boy, talk about negative cross influence of objectives here.
I think it's worth getting into specifics because there's people out there who might be curious about, well, what does overtraining even look like? And we haven't really discussed that. But in my clinic, we probably see 100 people a week at least. And so we do have protocols for this. And if we have somebody who comes in with some known injuries and we're doing some training, we inform our staff to look out for things like if they get a facial tic, they're done for the day, stop. And also we're going to mark in the note at what time did they have that response. And you're going to do that every time, and we're going to back it up 2 minutes. So we're not going to go that long next time. If they get a headache, they're done. If they get nausea, they're done. We're going to stop the session. We're going to look for other symptoms as well and be open to whatever the brain could do, because the brain's a big place, and that kind of ischemia, depending on the location, could cause arguably anything. But we do see things like headaches and nausea and facial tics being like the most common symptoms, even though there's a lot of range. I would also say that those things tend to occur fairly quick in training when you do overtraining, and that's not something that happens 10, 15 sessions in. That happens on session 2 or 3. The brain's very, very quick to over-respond, because I think that, and Jay might be able to speak to this more, but I don't know what the brain is doing following an injury. That's what I don't know. But I do know that it's very quick to try some things that it used to do, whether that it cannot do properly anymore. And neurofeedback perturbs it and gets it moving again. And it's very quick to try some things that it used to do that it can't do anymore the same way. And that's where that kind of increased hypoxia comes from that increased activation. And we don't have the resources and the circulation ability to sustain that level of activation. And that's where you can get your client in a little bit of trouble and get some of those side effects that you should be avoiding when you're doing training. I don't know if Jay has something to add to that or not, but
that's good.
Always.
Well, that's true too. When doing stimulation, you need to be very, very sensitive to the brevity of the first few sessions. Don't try to go for a long session. Deliberately do a short session. Don't induce the problem if you can avoid inducing it. And you can extend the time if the time that you've done doesn't trigger something. So don't go for a half-hour session first time. Go for a 5-minute session. And if there's a symptom before 5 minutes, you really have something set wrong. But if 5 minute works well, next time stretch it out. Maybe a 10-minute session, but don't jump ahead to the half-hour session. For the first few, and you're going to have a pretty good idea what's going on if you watch the level of activity that the brain is putting out. Yeah, don't let them try the old. They remember being an athlete, and they're not anymore. So don't let them get back into the saddle the way they used to. They have to know that this is being done slowly for a reason, and to avoid going slowly is going to make a problem.
I did some rotational work at Walter Reed when I worked for the Army, and physical therapy, they won't let them overextend themselves for the same reasons. The patient says, I can do more, and the therapist says, no, you're done. That's not always about their physical limitations. That can be about the neurological limitations just as much.
Yeah.
For the same reasons.
A little something in here though as well, that it's one thing when we're talking about supposedly no neuroinflammation results from concussion, etc. But for clients who come from different reasons, sometimes I want to throw headaches up. It makes a lot of sense to talk with the client about whether this could be a tension headache because they're focusing harder. So, for example, somebody's really putting themselves into a treatment focusing on ADHD. Another one is sometimes when we increase blood flow to the brain, which we do know that neurotherapy can potentiate. Sometimes that can be misinterpreted because people are not used to that sensation. So I say you have to be really careful about everything that we're saying as a globalization for all of the treatments.
Our guy Christian, is it common to see patients, clients, especially after head injury, to present symptoms like nausea and headaches after neurofeedback?
Sounded like he was addressing him. I thought it was.
I got you, Christian. Don't worry about it. Shane, you're next.
Post-traumatic ischemic headache.
Mm-hmm.
It's that pounding headache you got from the concussion. It's the ischemia, like a migraine ischemia is a pounding headache. It's ischemia.
Yeah.
And if you have a concussion with ischemic headache, you've done yourself some damage.
Yeah.
Hopefully you don't overdo it trying to get back on the field of play too early, because that can be at a cellular level a death sentence for some cells. So
I'm really conservative. If somebody comes in post concussion with an active headache, I'd say come back when the headache is gone, or please go back to the hospital and check out these headaches. We really have to work with our colleagues. So if somebody comes in with a known concussion and an active headache, no, it's like somebody coming in with an open gash and doing their exercises.
Is there anything we can tell them ethically? I know that we're all different scopes of practice, but what kinds of advice can we give them if they're in our office and they're here and we're saying, hey, go back to your doctor, but maybe drink more water, maybe what else do you got,
Yeah, rest, nutrition, hydration, stress reduction, all
avoid LEDs.
And please address the disclaimer at the beginning of the show. Please check with your primary care physician and mental health. Thank you. Shane Bauer, hello. I'm new to learning about neurofeedback for my son who's on the autism spectrum. I've seen these at-home headsets such as Mendy and Muse. Any thoughts? I assume clinical neurofeedback is best. Great assumption, Shane.
Shane, you've answered your own question. Listen, I came into this field because my daughter was diagnosed on the spectrum. It was my entry point, and I went to the Othamers, who very graciously sold me some equipment back when you could still buy it from them directly. You can't anymore, but back in the day, in the more wild and woolly West, it was still available for parents like myself, staring at tens of thousands of dollars worth of hours that was going to take to work with my daughter to say, hey, I'll do this at home with her and get the training. And I went through the trainings, et cetera, et cetera. That's the long story. But yes, you're on the right track. I think neurofeedback would be awesome for your son. I don't have much use for the Mendes and Muses of the world, to be honest with you. It's prefrontal training, and it's got its limitations. There's nothing wrong with it.
Lucky if that did the trick, like extremely lucky.
No, John and I have had little kangaroo boxing matches on this and have come to peace that, the days of just picking up equipment and working on your own child without an extreme, like you need mentorship. And I think everybody needs to hear John's backstory on this, that he was not being a cowboy. He wasn't just going out there, let's play with that. And so many people get that impression, and especially with these wellness products, etc., and no direction. I mean, any condition you can make better with neurotherapy, you can make worse with neurotherapy without a qualified instrument and a qualified practitioner.
How does he find that? How does he find that?
Yeah, Mari, thank you for bailing me out a little bit on that, because I wasn't as clear as I needed to be. I absolutely took many training courses with the Othamers. I was supervised by them. I knew by the time I was doing it on my daughter's head, I was very comfortable that I was doing the right thing, and I had a lot of backup. This isn't something you go buy something on eBay and just start strapping yourself in. That's crazy. Don't do that.
Home training is not a mistake, however. It should be supervised home training with a professional at the other end doing the supervision. That can be done on a Zoom type session. You can see where the electrode was put. You can operate the software at a distance. When working with intractable epileptics, we expect to do over 100 sessions. And just the logistics of going to the office and back. I mean, if you lived in LA and had to go over the Sepulveda Pass 100 times, that you wouldn't do it, So the logistics get in the way. And home training is the way to get around that logistics problem. You still have to get it set up with a clinical practitioner. They have to figure out the protocol appropriately. But once all of that's done, at this point, you can have 4 channels up to 19 channels done real time online at a distance with high quality amplifiers. Some of them dry sensors, but most of the training on a dry sensor ends up having contact jitter difficulties. So you have to be very cautious of the quality of the device if it's a dry sensor.
Yeah, and make sure that you also know how to read the impedance, the artifact, or that you're showing a live screen to whomever is guiding you. I mean, everybody knows I'm the conservative on this panel, and I'm really, really happy to have that position. As I always say, power goes both ways.
This one's for Mari too, Mari and others.
Okay. For somebody coming in with an active post-concussive headache, would you consider HRV or similar training, or not do any training? Well, you're going to get my "it depends" answer. If you've got a massive, big, pulsing headache that Jay was referring to, we don't want to do anything. You might want to consider some temperature regulation or some basic bio to just see whether you can get the generalized arousal down. I don't claim to be an HRV expert, but I mean, if you want to do some breath work a little bit to take it down, but I don't want to be pushing your resonant frequency. I would go really, really conservative on this. But again, I don't have a lot of information with an active post-concussive headache. I mean, there are headaches and there are headaches.
The term active post-concussive headache means that they need to be going for assessment. If you have a post-concussive headache, you have, if you're lucky, just ischemia. At worst, you may have a bleed.
Yep.
If the bleed is subdural, you can last a long time with a subdural. But if it's an epidural, you have a matter of hours if you're lucky. Very seldom more than hours. You need to be seen. And if somebody has a post-concussive acute circumstance with a headache, that's time for the urgent care facility, not neurofeedback or biofeedback at that point. When they come in the door with a fresh scrape and they say, I just hit my head and I got this headache, this is time for urgent care, not for not for HRV or any neurofeedback.
We've all had that. I've had people come in where, the eye is still bleeding, help, and I'm like, you're in the wrong location. Go around the corner to the hospital, please. Yeah. No,
Well,
we
we're-
get the humor, but it's lovely that people have such confidence in our profession, but we all have to know not just our scope of practice, but when to send people to the right place. Yeah, and
They could have come to me. I would have given them a patch.
Yeah, there we go.
Have you guys noticed ethnical, cultural, gender differences when applying neurofeedback? It could be from the logistics of it to actual biomarkers. Jay, we did a show on getting the right sensors to get through thick hair afro. Yeah. Remember?
There are papers that have been published recently on the negative lack of care, basically, that's provided to people with hair. Now, Maury's got hair, but some of us don't. And but when you've got hair that's in braids and weaves, and that makes the application of the electrode very, very difficult. There are people working on it. They've got, the big hair clamps that clamp. You could hold all your hair back with it. Very, very small ones with the same kind of design. The tips of them are electrodes, and you can clamp, and it will hold through the hair. You can grab onto the base of a dreadlock and have the electrode in contact. So they're getting around some of it, but there's still a problem. And pasting on individual discs will work, but it's a mess. If you paste it on 19 to do an assessment, you know how big a mess it can be.
Oh, it can be a lot of fun.
This is where 1 and 2 channel work sometimes. The good old fashioned stuff works.
Yeah.
No, we're so ethnocentric in terms of who develops the devices and why they're developed, and some of it is just out of cultural or ethnical ignorance, and some of it, we can really get into the politics, but we have to work with what we have. I say with a certain amount of pride that we have a disproportionate amount of people of African heritage coming to the Swingle clinic because we know what to do with springy hair. Does it take twice as long? Yes, but we know what to do. Now, my hair is big, but I don't have that tight spring, so we can dig in and clip. But essentially, you've got to get a full pack of hairdresser clips and just and you're checking your impedance constantly. And I just, lots of humor. There's a price for your beautiful hair, okay? And I said, I don't want to shave your head. Do you want to shave your head? Just all kinds of humor.
That's Irish afro.
That you make the effort. Yeah.
In the publication, they actually had, if you go to a hairdresser, there's patterns that can be done that leave all the electrode sites free.
I love it.
Lord, that's
brilliant. Even if somebody does have the tight, I don't know the actual hairstyle, but essentially the hairdresser takes, or the parent, whoever's braiding your hair, it's like a square patch, and you can, if you're lucky, you can get between the middle of the squares, or you can even weave the electrode underneath and squish the braid down. So it's just a matter of experience and patience. And as Jay was saying, we're getting some really good what are they, the octopus electrodes? Jay, what are those ones called? The ones that they have these long tongs coming down. Anyways, I'm hoping that those will become more and more common, so that, do you have them there? Yeah. Those super long ones, unfortunately, they're not compatible with the equipment we use, so we're still using 101 hairstylist pins, but there's a will, there's a way. So
let's just go back to needles.
Attached to batteries, right?
Yeah, exactly. Not to scare the audience, but that's how it was done. Well, how many years ago?
Sure.
This is talking 40, 50 years ago.
That's when I started. We used needle electrodes.
All right, we don't need to lose any viewers.
That's right.
Yeah, Joshua, the biomarkers.
They're basically suggesting in the all the ASSET, which is the American Society for Electro-Neurodiagnostic Technologists, they have recommendations against using needle electrodes unless there's no other method that can be used. Now, there's times when the skin's been abraded from road rash that you can't paste something on. And in those circumstances, those extremely rare circumstances, the person may not even be conscious for the study. So, there's times. But when I started, 21 needles were stuck in your head. Now, the reason we knocked the kids out before they had their EEG was no kid will put up with 21 needles being stuck in their head. So they got chloral hydrate unconscious before they were hooked up. Now,
okay, we're going to be
what
banned.
kind of an EEG are you going to get out of somebody sedated unconscious,
Yeah,
So
Pete
we don't do it
desperately
anymore.
wants to change the subject. Pete desperately wants to change.
We're losing viewers. They're like,
There's no edit here. Poor Christian was like, that's crazy. I know.
Let's talk about gender then. Let's just go
They weren't the
smoothly
good
into
old
another
days. They were the bad old days.
They were the bad old days, exactly.
Yeah. So the
man.
other half of the question was if there were differences in neuromarkers, and Jay can probably cite this from memory, but there is studies showing that essentially, mostly no, there is no difference between ethnicity and race.
Yeah.
Between
that was a big question early in the QEEG days. Frank Duffy, Roy John, all of them got together and said, we need to go out and study this. Where are the possible different people? Well, maybe the Aleutian Islanders, maybe the Aboriginals here or there, the Pygmies in Africa, various racial groups and so forth. And they went hunting for various folks that would possibly be different. And what they found is that a normal brain without trauma or meds or whatever is a normal brain is a normal brain. And there's no racial or cultural difference that's significant. Now, that was using a few people to judge against the large database. If you're really looking at statistics, you have to have a similar size to compare two groups. So now that they have full databases collected in Switzerland and Russia compared to the database in South Korea, there's subtle differences, but normal is generally still normal. The event-related potential in the Swiss-Russian database has more left side processing. The Koreans have more bilateral processing, but the latency and everything for the event-related potential gets there. And it's not like their P300 is late or early or something. There's different styles of processing, but there's no racial or cultural differences that are significant.
What about gender?
Yeah, I was just going to say
gender. If I can jump in.
Gender differences are.
Yeah, if I could jump in a little bit in terms of, and maybe get ourselves in trouble a little bit, but first of all, there's no such thing as race. Okay, we've got one race. What we're talking about is, if at best, ethnicity, but we're also talking about phenotype. Okay, so visible phenotype, and I'm not talking about brain phenotypes. I'm talking about visual phenotypes. Okay, just because somebody looks like they're from the Pacific Rim, or just like if somebody looks like they're from Africa, tells you that one parent probably is. In terms of, if we're looking at purebred, if we want to get really into negative terms of race, versus mutts, or mixed races, most Caucasian individuals, we're all mutts. We're these incredible mixes. And some of the we did some work with First Nations peoples, and we actually did find some differences. But it's kind of really, really sad and very true that we're not sure whether this is about genetic purity or horrible shared traumatic experience. right? And how can we write on this? I mean, talk about a huge, it depends. So we have these vigilant signatures that if you look that not too many generations back, you have a very, very pure race of individuals who were hunters. That would make sense. But that also makes sense for a population that was subjected to horrible traumas. So we can't talk about this. We just don't know. Anybody else want to chime in on that one? I mean, it's very political, but I think we need to go there.
No, I think you're spot on. We don't know. I mean, we all have to be comfortable. Obviously, we all work in the brain space, and we all go, yeah, we know a lot. There's so much more to know. Good Lord, Jay has held forth on this endlessly, and is, of course, 100% correct. We know what we know, and there's a crap load we don't know.
Yeah.
And it's hubristic to think we can start making these wild, pronouncements about cultural identity and heritage and biomarkers. It's silly. Come on.
Yeah.
You're right. We're one race.
Historically, the databases were all male and female combined.
Exactly.
Yeah.
And they looked for the normative mean and standard deviation for the age range, and that was it. The Koreans, when they were setting up to do their database collection, I advised them that they shouldn't listen to me, but they did anyway. And I told them that it was going to take twice as much work, and they did it anyway.
Good.
Collect totally separate databases for male and female. And you can't take a normative database and cut it in half and have a full-size database. So you have to collect two full-size normative populations. And they did that extra work. And thank goodness the obvious differences between male and female structures of brains on the average end up panning out to actually have differences, because if I would have made my dear friends work twice as hard for no reason, I would have felt bad. But it worked out that there is, in fact, a difference between male and female dramatically during the developmental trajectory. And then again, 45 years old on up, males and females separate really dramatically. So they were very happy.
Say it, Jay. Who gets smarter?
It was important to see the difference, because NIMH has said we now have to actually not just study males for drugs. They have to bring in males and females. And if you're using a normative database, you should have one that's appropriate to the gender of the person that you're working with. Not a unique database, an averaging. So,
all right, on that note, who wants to read the next one? Art of Soma asks, hi, could someone explain the difference of amplitude neurofeedback versus HPN? I work at the brain training of NE in Maine. Free plug.
I think the HPN is referring to a specific technique that uses stimulation as well as feedback, and it's a proprietary device approach. Now, stimulation and neurofeedback go together very nicely. I won't speak to the HPN device itself. But stimulation provides, after the stimulation, a brief period of enhanced neuroplasticity, and that's a wonderful time to train. If your system is too stable, it's hard to learn operantly from it. It's not a good operant. But if after the stimulation, the system has got changes going on, that's the time to train. So stimulation and neurofeedback go well together. Following the stimulation, doing neurofeedback allows you to have a more operantly trainable neural system. And although nobody has actually done the horse race of randomizing people into the different treatment approaches and seeing whether the combination is faster or not, people that do it feel like it is, but then every time people come up with something new, they feel like it's better bigger, better, faster than the older stuff. So
Yeah.
it really needs to have the studies done. But it appears that the enhancement of the neuroplasticity from STIM gives neurofeedback a little leg up over a routine session.
Michael asks, are nasopharyngeal leads ever used today? So this is not photo biomodulation. This is like actual leads. I don't know what he's talking about.
So nasopharyngeal are PG1 and PG2 electrodes. They're about that, or about a foot long. They have a 1 centimeter silver ball on the end, and the experience is like sticking the entire little finger to the hilt up your nose. It's a 1 centimeter
I think
ball.
Michael's teasing us here.
Oh my God.
You feed the wire up through the nostril to the base of the forebrain. It's really not done anymore. It used to be part of a lot of routine laboratory procedures, but it's not done anymore.
If you think the COVID nasal thing is bad.
No, this.
Way to sneak one in, Michael.
Wow.
Yeah.
PG1 and PG2 are you'll still see them on some of the old head boxes, but you don't expect to see somebody know what
And
to
in
do with
horror
them.
shows.
Yeah.
Dry or wet
I
sensor.
want Michael to tell us whether that was just was that a probing question, or was
I
he
want
serious?
Michael to take a long walk on a short pier. What are your thoughts on dry or wet sensors that are coming out as opposed to using conductive pace in terms of digital signal processing?
I have not used any of the dry sensors. I had that $20,000 rig put on my head, and I said, I can't wear this for more than 10 minutes. This is with the ratchet thing. I'm like, I'm out. For 20 grand, I'm not even.
Sensor? They're
Say
all
again?
wet. Is there a such thing as a dry sensor?
Right here.
Yeah.
I thought they're all. You got to have some kind of moisture in there.
If it's metallic, it's not a good dry sensor because that has contact jitter. Any of the better designed ones have a polymer coating. They may be polymer over top of silver chloride if they're really well designed, but that polymer ends up being a damp. It picks up moisture from the skin, and quite a few of the dry sensor companies actually have the ability to put a little bit of water on their sensor or water on the hair next to where the sensor is going to be if you can't get good contact. So the polymer coating ends up making a gigantic difference in the quality of the signal because it maintains better contact. Solid metal, shiny metal contacts are not going to give good contact. That said, the dry sensors have a super high input impedance. So the skin impedance itself, as long as you're maintaining contact, the skin impedance is relatively irrelevant. You don't need to be between 1K and 5K ohms of resistance and balanced plus minus 1K because the input impedance on the amplifier is so high, skin impedance between 1 and 1,000 isn't any different. That's an insignificant difference compared to the input impedance. So the modern amplifiers make skin contact other than actually having some contact irrelevant. Impedance isn't tested. DC offset is. You see if there's electrode contact. If they're in contact, that's fine. The very high density, you've probably seen they soak them and then they just put them on. It's a grid of electrodes, 256 spots. You've seen perhaps the Dalai Lama's monks on a cover of a magazine with a grid of electrodes over their head. You know how they make electrode contact for those? If your amp doesn't qualify, they take a lance. 256 times you're going to get poked with a needle to make contact.
We're back to that again.
If your amp qualifies, you don't have to do any of that. You just have to show that there's no DC offset. You've got skin
Guys,
contact.
this is not good publicity for our
We're doing the thing again.
We're back to the needles again.
It's real, you know.
Jay, is
the
it
reality
true
is 256 electrodes is only in a research laboratory. You're not going to walk into a clinical operation and have 256 electrodes put on your head for any reason for clinical purposes. That's a research tool.
underlying this conversation for me is the Muse headband going to give you an adequate signal for processing for neurofeedback? I don't pick out the. I'll pick out the. There are others. I should just pick out Muse. There are other of these. Inexpensive.
If you're doing ERPs, it's okay, because for event-related potentials, the EEG averages out.
Mm-hmm.
So, is it adequate for EEG? Not really, but event-related potentials are average, a whole bunch of them together.
Right.
You can get a pretty good ERP signal out of a reasonably cheaper amp. But
right, but I think that underlying Craig's question of frontal placements of sensors, I'm going to infer there's the handful. I mentioned one. There are others similarly designed because of the the physical reality of how do you affix something to someone's head. You're kind of left with a headband arrangement. There's not much else you can do. So a lot of times it's
spandex caps like Electrocap International.
Right.
The spandex cap ends up being done for brain bit. And they have dry sensors that are put whichever one of the 10-20 sites you want to use, for 4 of them all the way up to 19 of them. And once you have that strapped on and stable, it gives you a reasonably good recording. It's not heavy. The electrodes aren't pin cushions, so it's not. It doesn't put people off the same way as some of the heavier headsets have.
Right.
But the brain bit has been demonstrated recently at the brain hacking. Giancarlo Licata took a 19-channel brain bit that he had pieced together to show the brain hackers kind of how it's done by somebody who knows what they're doing. And I think he duly impressed them.
Well, exactly, but that's part of the question. Anybody, average consumer tuning into this, they're seeing on Amazon or they're seeing in their feed, some advertisement for, I've got this, Lycra sock with a couple of sensors built into the front, and it's going to do neurofeedback and it's going to cure your anxiety. That's what they're seeing in the advertising.
Yeah.
And I think that's kind of I think what we're all talking about here is, I think the signal quality is insufficient. I can't even imagine what the algorithms are.
The claims of the manufacturer are beyond general health and wellness at that point. Yeah. So you need to watch what you're purchasing. It's still buyer beware out there. It's and you can buy good remote training devices. You can buy good dry sensor devices, but don't expect them to be cheap necessarily.
Right.
So,
because that's the byline on all of this is people are looking for the answer to why is helping my brain reorganize, get better, whatever their metaphor is for it. Why is it so expensive and why does it take so long? Because professionals. Yeah.
Sorry, you were going right there because you want somebody who knows what the they're doing on equipment that does what the it says it does.
No editing necessary, Pete.
This is the Demonetization Podcast. I'm Pete Jansons, your host.
No, I just get so frustrated with this. It's like, why does a surgeon who does knee replacements have to go to school for 10 years? Because you want the person replacing your knee to know what they're doing. Okay. Right. Why does it cost that much for the surgery? Because, it's the same type of thing. And we have this trend now where we're just simplifying the brain to this extent. I mean, we take the joint in our fingers more seriously now, sometimes in terms of who puts the splint on and how it's splinted, than some of these very, very serious issues, whether we're talking about even garden variety, anxiety, and depression. You want somebody who knows what they're doing with verified, qualified equipment, or who knows enough if they're using a different form of equipment to know the limitations of that equipment.
Right.
Yeah.
But Mark,
if you see the sign Joe's Neurosurgery, $200 for the works, maybe it's not the right place to go.
But all humor, but people aren't putting out Joe's neurosurgery. They're Joe this, that, and the other. This fancy topography issue, this lightning strike on the brain, and I really feel not just for the consumer now, but even qualified professionals can't tell the difference between the flash and pan and somebody who really knows what they're doing. And also, many kudos to many individuals, those of us who state what our limitations are.
We have professional societies that are membership organizations that have member lists, and that's a good place to go to see if somebody's kind of generally interested in this field. But there's also certification societies, and they're really a base level of certification. It's not that it's going to be the highest level of certification, but it shows that they've done their due diligence and have taken some didactic courses and done some simple written exams to show that they're somewhat qualified. So if you want to, you can actually find people with some base level qualifications that are certified. It isn't just blind searching. BCIA, AAPB, ISNR, BFE over in Europe, SAN in Europe, the Australasian Society in Australia and the Asian Peninsula areas. There's a Spanish society. There's an Italian society, and if you're a consumer and you're looking, look for the professionals, not Joe's Neurosurgery $200 for the works. And the reason that things are expensive is that life is expensive. And the first amplifier I bought for QEEG was $160,000, and I had to get 4 of them for the lab. How do you amortize that? The price went down to $60,000 for the QSI QEEG machine out of Canada, but that's still more than people want to pay. Now you can buy a good QEEG machine well under $10,000, and probably have enough to go out for a nice dinner left over. So
I'm gonna get wired on this one, as everybody knows, and maybe pipe me down or Pete mute me at some point. But this is something that's so close to my professional heart. I mean, even we can't forget. I mean, bless BCIA. I'm all for it. Yes, yes, yes. But you only need a bachelor's of psychology for BCI certification. Now, I do not want to undermine BCI certification. Don't get me wrong. But when Jay said this is base entry, so you can have PhD level, MD, psychiatry, PhD, all the way down to a BA. So you want to check the complementary competence. Now, there's a lot somebody with a BA in psychology with BCIA and good training and mentorship can do. Don't get me wrong on that, but you have to know that there are massive differences between the equipment, the practitioner, and what Jay was saying as well, the cost of, I would say, the more difficult equipment. So the equipment that people really, really need to know what they're doing is very expensive. And equally, the equipment that people really don't need to know what they're doing is equally expensive. So, okay, mute me, Pete, for 5 minutes so others talk.
No, Mari, to your point, you can imagine what a $10,000 or $20,000 setup in an office can do versus a $300, plastic device and an Apatophone.
Yeah,
it doesn't take a rocket scientist to put those two things in comparison to each other. It's obvious the difference. Now, how well do you want to treat your brain? That's the answer. You want to treat it gracefully with professional oversight, or do you want to just go out there and see what happens?
But we want to add, though, pretty pictures, meaning your screen display is not the differentiating factor. And that's amazing. Well, no, we got to put that one out there as well. Somebody has better images. Well, the only person that needs to read those images is the person qualified to read them. It's not about the beauty of the image. It's about the information the image gives you. I'm going to auto mute now.
The analogy of a rocket scientist is not really a great one right now. Everything that's landed on the moon lately has fallen over. And we got some people stuck on the International Space Station on a return voyage that they kind of crossed their fingers and hope Boeing might make it work. We've blown up one of Musk's reliable vehicles. China just lost one. I mean, rocket science is still not something that we're doing very well. So let's not put that up as the thing. Perhaps brain surgery by somebody who's competent, as an analogy, that's complex and expensive.
Exactly.
And I recommend brain surgery highly if you need it. But.
Is anybody going to make the crack about the person blowing up rocket ships is now the person who wants to treat your brain? Craig is just saying thanks for chatting.
Well, thank you, Craig. A lot of great questions, my man. I don't know who you are. But
he's an EEG tech.
Yeah,
I recognize his name.
These dry sensors, Craig, will not likely be used for slow cortical treatments or trainings or anything that uses them, by the way. The data on them suggests that they're not going to be adequate for that. So some of the things that Craig does, probably not going to see them used for that.
You've got to, if you're going to be doing slow cortical potential, you've got to have the right kind of electrodes, and you can't be sloppy with your work. Barry Sturman actually did slow cortical potential research before he did SMR, and he abandoned it it was too difficult to get good results. You have to control for eye movement and tongue movement and electrodermal activity, and there's so many slow signals that can get in the way of a good signal. So that the EEG was so much cleaner than the slow cortical potential, which was very difficult. But you have to remember, historically, slow cortical potentials were difficult to record because the amps were not stable. So,
I think Yuri published something on that last year. It was like brutal. And I know that Yuri's been doing a lot of work with the ophmers lately. And so he's getting quite involved with it. So it will be interesting, but that paper was like, oof, this is delicate, very delicate stuff.
There is long history of people working in infralow frequency, and Yuri was one of the very early folks working in that area. He identified using gold electrodes with a polarization, the decasecond, 10-second long oxygenation cycle in the brain, which is basically the basis of the HRV stuff that we're dealing with, trying to synchronize with that. Anyway, there is a long-standing history of people looking at very low frequencies, and it's very fastidious work. You can't do it without extreme controls. So,
and for any casual observer, just person looking to say, what's this neurofeedback thing all about? You can hear from this conversation just how complicated it actually is. This is so much deeper than anybody can possibly imagine. Jay's probably got the best vantage point. I don't want to disrespect anybody. Jay's got a terrific vantage point on this entire industry. So
is that our disclaimer?
Is that my disclaimer? Yeah, that's what I'll get in trouble with any of y'all.
I think that's a fantastic takeaway. I really do.
This is what consumers need to know. This is your brain. It's incredibly complex. It's incredibly complicated. The people who do this work are gifted, and they train, and they continue to train, and we continue to try to understand as best we can what's going on between your ears. And this isn't something to hand over to Joe's neurosurgery, whatever you called it, with the neon sign on the corner. That's not how this works.
Yeah.
We can work with very, very badly damaged and not very functional brains and make them work well. But we can also take somebody who's working well and optimize their performance.
Yeah.
And there isn't anybody out there that you bring me their EEG and I look at it that I can't say, well, a tune-up over here could make this. If you go to Indianapolis 500, high performance doesn't mean you don't need a tune-up. For God's sakes, they tune those things up constantly.
During the race.
The higher the performance you want to have, the more likely you are to need a tune-up.
Yep.
And the brain training is, simplistically looked at, it's a tune-up.
Yeah.
We're not doing brain surgery. We do alter white matter and gray matter with the training, but we don't go in after it. We train it from the surface, and what we're training ends up being the world's most complicated puzzle.
Yeah.
And there are very few that understand it deeply enough to know when they look at the surface EEG kind of what it needs. But there are those folks out there in the neurotherapy world, and you can get your EEG assessed. A plan can be put in front of you so you can understand what they're intending to do and train and why, and training can be done. Depending upon what kind of client it is, it's going to take a different amount of time.
Right.
Simple ADD, if there's anything such thing as a simple ADD, 30, 40 sessions, half hour a piece, probably fairly adequate. If there's a learning disability added on, it takes longer. There's a learning disability. It's 40 to 60. Autism, 60 to 80. Epilepsy, we usually quote 100 or more. I've seen it done faster, but we don't want to give a false expectation of something that's quick.
Can I underline two words, Jay, that you said? What and why? I'm sure everybody heard that. You want your provider to tell you what they're doing and why they're doing it. Maybe
Josh,
how.
what's checking with you last? Did you get everything out of your system?
I did. I think so. Thank you.
I like this live idea. I want honestly, by my own, I want more just regular blokes tuning in and asking what we might perceive as really rudimentary questions, because that's what I keep getting asked.
Yeah.
And I get people calling me up going, what literally still, what's neurofeedback?
Yeah.
They're calling me at least, but they really have only a vague notion. Friend told them about it. Somebody's kid, went and did it, and they helped his kid with ADD. Maybe it'll help me. I'm a 35-year-old with ADD. Maybe it'll help me. But I mean, they literally know relatively little about the process or its history. Yeah. And I love this idea of a live show. If we can capture some of this random folks who are scrolling through Facebook right now, going, God, here's this product that's telling me I can do this for,
I think like we're known within our community. I think this is about not the right time. It's about time. You kind of build, it spreads through to, I could put it on in the waiting room here, so that your clients can share it with
We should talk less about needles.
Sorry? Yeah.
Needles are the nose thing. That's like, I wanted to hit delete.
Well, the reality is reality, though. So
I tease.
I think I started that conversation. I apologize. I think I'm the one who said needles.
You're the needle man.
They're going to therapy. They'll be fine. No.
Oh, is this the way you're getting new clients? Scare them from coming to your needle phobia.
Oh my God.
But when I started, we used both. So
I got that from you, Jay.
Now,
I got that from you, Jay.
We've gotten away from them because you should get away from them. There's comfortable, appropriate methods nowadays. Some of them don't make a mess of your hair. Assume you have hair. But our field is a unique field in that our clients don't know who we are, they don't know what we do, and they don't know how to get a hold of us. So, we're not in competition. We're not in competition with each other. If you have another neurofeedback person open up something near you, it raises the profile of the field slightly in your area. If you own an antique store, you want another antique store in the area, so you become an antique district. So it floats all the boats better to have the competition, but not to be actually competitive, but to be co-opetition, which is a totally different model. You know, it's a model for an immature market where the clients don't know who you are, what you do, and how to get a hold of you. As soon as they know who we are, what we do, and how to get a hold of all of us, then we're in competition. You're interested in what the radius of your slice of the pie is right now, not how big your piece is.
Right.
Ladies and gentlemen, Dr. Marie Swingle, Joshua Moore, John Mekrut, Jay Gunkelman, the inaugural, the first edition of the live Neurofeedback.
Thank you, Pete. Thank you, Pete.
Thank you,
for all
Pete,
of
for
your
sending
work on NeuroNoodle.
Oh, crap. Did I hit record? Bye, all.
Hey everyone, if you're enjoying the show and want to help us keep it going, please consider supporting us on Patreon. Your support helps improve the content and brings on great guests and grow the show. Join us on Patreon at patreon.com/NeuroNoodle. But hey, if supporting financially isn't in the cards right now, no worries. You can still help us out for free by liking, subscribing, and sharing this episode. It really makes a difference and helps more people find the show. If we've earned it, hit that subscribe button and turn on notifications so you never miss an episode. The NeuroNoodle podcast is supported by listeners and businesses just like you. Hey everyone, here's a quick message from our good old buddy Joshua Moore at Alternative Behavioral Therapy.
I'm preparing to do an introduction to QEEG phenotypes. This is my first workshop on the topic, and this is just the introductory overview of the project. This is going to be very, very basic. So let's review each phenotype. We're just going to go through them one by one. If you look at the DSM-1, 2, or 3, and you look at the first chapter, it actually acknowledges that the DSM in mental health is just, quote, a descriptive adaptation, unquote. We're going to customize the interventions and tailor them to the individual's brain activity, not just applying the treatments or trainings to the individual's phenotype and maybe even their variants, but also customizing the protocols themselves to fit that person's individual unique frequency patterns. Maybe a dozen ways to have excessive energy in your nervous system, and then there's an infinite amount of ways to relate poorly to that excessive energy, which means that there is a lot of variations in what someone might call anxiety. And that doesn't mean that we're talking about the same thing when we're talking about anxiety. So complicated stuff. But when we look at a brain map, we get some basis in which we can start talking about what is this energy. Then we have to go to the client. We have to start talking to the client about what is your association to this specific kind of energy that I can see now. Then we get to care about things that insurance doesn't restrict us on. We get to care about like the person in a broader way. 85% improvement in mental health report following pairing a medication with a specific phenotype. You know, geez. Okay, have you seen 85% in any mental health studies for any medication? I'm going to be going over a whole bunch of different types of tests, assessments, and things that can be used that have things called neurocorrelates, which you saw some of those already. Better success outcomes. That's what we really want. We need better predictive power. We need better individualization. That's what we want.